I'm ready to go now and just a little. Okay, so we're going to talk today about management. Last week we talked about, we just covered almost everything about breast surgery from skin to skin in 1.5 hours. But today we're going to talk about management of a breast lump. Again, we're going to be very basic. We'll get into details, and then we'll talk more and more about oncoplasty and conservative surgery in the future. Certainly, I'm glad Farid is with us, so he will sponsor one of our meetings in the future, inshallah, about oncoplasty. So let's start talking about management of a breast lump. But please, before you management, there's something really not really very good. We see it a lot in Egypt here and in many Arab countries I worked in, which is operating with an excision biopsy. And that it can go up to be a crime in today's practice. You should never, ever, ever operate on a breast lump without a core biopsy, please. So I'm talking just a little about the necessity of core biopsy, because to plan a good management, you have to have a full, almost full diagnosis before you start the treatment. You need to know what is the status of the axilla, what is the pathology, what are the receptors, what are the receptors. When you inform the patient properly, you really get them ready and you get the best plan of action. We all do right, but we want to do the best possible, not just what is right, we want to do the best. So I'll just talk a little about the necessity of core biopsy. Right, so why should we do a core biopsy? We can never know the true nature of the disease. It's very different when you're talking about DCIS, we're talking invasive, and invasive lobular could be totally different from invasive ductal, from metaplastic carcinoma, from papillary, from. So they're not all the same. And knowing in advance what you're dealing with, you will get the best plan of management. So please, please, please refrain from excision biopsy and insist on core biopsy. If you don't now know how to do it, there are centers who will do it for you, please. Sometimes upfront medical treatment, neoadjuvant chemotherapy might help you as a surgeon and might even help improve survival, disease-free survival, and even might save the patient axillary clearance. Instead of clearance, you might go for a sentinel node if they get good response. Even you might choose a better reconstructive management. You can never, for instance, invasive lobular carcinoma on a core biopsy, you might like to get an MRI first because of the multifocality. There are lots of contralaterality in them. So you really need a core biopsy. So you really don't deprive the patient from the best possible management plan. So please, 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 you have to talk about core biopsy, get full assessment, and when you have cancer, insist for the radiologist to do a proper assessment of the axilla, and any abnormal lymph node should have at least a 5-needle aspirate. So we'll also help you plan the surgical management of the axilla. Instead of doing a sentinel node, if you know in advance that it is the FNA is positive, you might go straight for clearance. If it is negative or a normal node, fair enough, then you can go for sentinel node. So please, it's very important to have proper assessment with a core biopsy of any breast tumor, and if it is cancer, proper assessment preoperatively of the axilla. We'll talk about in a simple guidance about the breast abnormalities. So we have some benign breast lumps, we have potentially malignant lesions on core biopsy, and we have lesions that have prognostic significance, and we have some locally malignant lesions, and of course we have the malignant lesion. So let's talk about the benign lesion. The importance of benign lesion really, when you talk about management, is actually to make sure it is not cancer, whether you're going to excise it or not. That's in simple terms. You just make sure you exclude cancer, you exclude malignancy, whether you're going to excise it, what size is it, if it is a fibroadenoma, how big is it before I remove it. Every hospital, every country, every person will set their threshold. But basically, the management is to make sure that it is not malignant. Most patients want to be assured that it is not malignant, whether you remove it or not. I'm not going to talk a lot about it because I'm sure you know it, We have the ANDI, aberration of normal development and involution, fibroadenoma, the giant fibroadenoma, cysts, benign phylloides, lipoma, sebaceous cysts do happen a lot on the breast, and granulomatous disease, granulomatous mastitis. It's amazing, Farid, how common it is in Egypt. And in England, I used to see once a year or so granulomatous mastitis, but I see every week about 3 granulomatous mastitis in Egypt. I have a massive number, and we all treat them with steroids here, and they respond very well. This is just a picture of one of the patients came in with horrible abscesses there, core biopsy, granulomatous mastitis, few weeks on cortisone and completely resolved. Of course, unfortunately, with a bit of scarring. So treatment for benign lumps is simply to make sure it's not malignant, and then what you're going to excise or blah, blah. I'm not going to talk a lot about it today, but let's talk about the potentially malignant. What do we mean by potentially malignant? You have a lesion, you take a core biopsy, it comes as benign, but please be careful because that needs to be excised completely to prove that there is no malignancy. You know, malignant lesions sometimes like marble, you have some stria in it and different colors in it. So a core biopsy might come and say ADH, and actually it was the edge of a more sinister disease, DCIS, or even invasive. So potentially malignant on core biopsy, they are benign, but these lesions have to be fully excised. Atypical ductal hyperplasia, sclerosing adenosis, radial scar, and papillary lesion. Radial scar is the young brother of sclerosing adenosis, and they're all mammographic abnormalities. They're very dense lesions, fibrotic lesions. You take the core biopsy, come back as sclerosing adenosis, radial scar. Please excise. And again, when you get a core biopsy saying ADH, it is benign, please excise to prove it is benign and it's not DCIS or invasive. Again, most papillary lesions, actually all papillary lesions, are very difficult to diagnose on core biopsy. Core biopsy cannot differentiate benign from malignant lesions. Will always come back the histology as indeterminate. So papillary lesions almost always need to be excised and to get full histological diagnosis, whether it's benign, there is invasion or not, and you can manage them. So these are the potentially malignant. The lesion on core biopsy that is of prognostic significance is the lobular carcinoma in situ. In the past, before 2000, we used to go for excision of this LCIS as if it is DCIS, but we actually discovered that 50% of them proved to be ductal, not lobular carcinoma in situ, and 50% could be on the contralateral breast. So whenever you get a core biopsy on LCIS, it is of prognostic value. Don't go for excision with a clear margin, but of course, if it presents as a lump, remove that lump because it could already be invasive. Again, 50% of the invasive they develop when you have a background of LCIS, lobular carcinoma in situ, will actually prove to be ductal, and 50% could happen in the contralateral side. So treat it as a high-risk prognostic factor, treat it as a family history, if I may say. Right. Locally malignant, we all talk about ductal carcinoma in situ. Ductal carcinoma in situ is a pre-malignant, it's a pre-invasive disease, I'm sorry, and it's a matter of time before it could breach the basement membrane and it turns into invasive disease. It's an opportunity and to cure a patient when you catch the disease as a DCIS, because it's a matter of time before it can reach the basement membrane. Which patient is going to turn into invasive and which is not, we don't know. So you all have to be treated surgically. What you're going to do with them? Yes, specifically, you need a margin always of 2 millimeters. And do we do another assessment or not? I'm going to talk about it later. Malignant lesions here. I put it in a very simple way. Malignant lesions, all the patients come to you, they don't want you to say you have a benign disease. They want you to say, I don't have a malignant disease. But malignant disease, unfortunately, do occur a lot with advancing ages and with a bit of family history. So what are the malignant diseases? We have primary diseases that affect the breast, primary malignancy in the breast, and we have metastasis that could happen in the breast. And I remember excising what looked to me as a superficial or possibly sebaceous cyst. I excised it, it came back as pancreatic metastasis. I've removed the lesion that proved to be metastasis from melanoma. So yes, metastasis does happen in a breast. And how do you treat it? You treat it as the primary lesion. Regarding the primary breast tumor that are not metastatic, we have the lymphoma, we have the sarcoma, I'm sorry, I brought E instead of A, and you have the carcinoma. So again, the secondary, you treat it as you treat the primary. But for the primaries, we have the lymphomas, we have the cystosarcoma phylloides or sarcomas, and we have the carcinoma. Let's talk about the lymphoma. It is embarrassing for you to get a lesion, breast tumor, you go and do excision biopsy, and it proves to be a lymphoma. Well, I'll kill myself if that happens, because it needs systemic treatment. There is no local treatment for a lymphoma. That highlights the necessity of having core biopsy, please. So you treat lymphoma with systemic therapy. What about sarcoma? We all know the cystosarcoma phylloides. You need to know it before you excise that lesion. Why is that? Because there are some specifics for the sarcoma that could be different from the carcinoma. You need very good local control with a margin, minimum 10 millimeter, even mastectomy if you have to do. And if it is too deep and touching the pectoralis major, I would really remove that part of pectoralis major that was there touching it. You don't need to remove any nodes with cystosarcoma phylloides unless they are really large on ultrasound, because less than 4% of them would have any nodal disease. So the rule is no nodal surgery, neither sentinel nor clearance. And you don't usually treat them with adjuvant chemotherapy unless there is metastasis. So if you refer them to a medical oncologist, they will observe after CT staging. And really not radiosensitive. They are not chemosensitive either. So you only use radiotherapy if it is recurrent excision of a disease and you cannot do any more excision. This is cystosarcoma phylloides. It just is, you need to know this on core biopsy. The carcinoma, which is the main thing we talk about. Again, when you manage carcinoma here, generally, you need to always think of these three things. What am I going to do for the local control? I have a carcinoma, you need local control. Mastectomy, lumpectomy, reconstruction, oncoplasty, that's called local control, plus or minus radiotherapy. Then you need regional control. Do I need to assess the lymph nodes? Because it tells you the behavior of the tumor. This is the lymph node, it's a very important marker. So you really need to know the status of the lymph nodes. Do I really need to do FNA in advance, sentinel node proceed to clearance, clearance level 1, 2, 3, we'll talk about it in a minute. And you need a systemic control. Now you've got a lot of information about this disease. Now you need to say, do I need to do some protection? I'm going to assume that there are some cells hiding behind here or there in the circulation, in the bone marrow. Do I really need to give some medication to control that systemic disease? So you need to consider the patient sitting in front of you as a breast, as an axilla, as a whole body that might need control. We'll talk about it. So carcinomas, let's just be very basic and simple and say, remember, invasive disease and carcinoma in situ. We just talked about ductal carcinoma in situ that did not breach the basement membrane, has no potential of spreading anywhere, neither to the lymph node nor to the distant parts of the body, but invasive. It has already breached the basement membrane and could spread somewhere. So you need to differentiate between carcinoma in situ and invasive, because that will make a difference to your management. And remember always, for simplicity, two letters, letter D and letter L, because 85% of the tumors arise from the ductal system. So we call them invasive ductal carcinoma or ductal carcinoma in situ. and 10 to 15% do develop from the lobules, and we call it the invasive lobular carcinoma or lobular carcinoma in situ. So you need to remember this, just these two letters, ductal, lobular, and invasive or carcinoma in situ. We just talked about lobular carcinoma in situ, that it is prognostic, and we don't excise it to a free margin anymore because you will not get a free margin with that. So that's why I put a cross now. Knowing that, that will help you after the core biopsy, will help you plan management, because I'll talk about it later. We have some other forms of tumor that invasive that possibly you don't have to remember them all, but one day we are going to talk about specific types of invasive cancer. So we have this invasive ductal, lobular. These are the main two types, but you have tubular, papillary, mucinous, metaplastic, medullary, you name it. But you need always to remember ductal and lobular. The management is very much similar, but for the lobular, of course, they don't show themselves very well on mammogram. You could be very large, and there is no mammogram reported normal, ultrasound reported normal. I had a young lady last week, not very young, she's 46, and she had a lump in her left breast. Mammogram is normal, ultrasound is normal, but I could feel unhappy feeling at the upper aspect of her left breast. We insisted on a core biopsy, and that came back as invasive lobular. She's now having an MRI, so we can plan her future management. So you just need to know ductal, lobular, invasive, and carcinoma in situ from the very beginning. Lobular carcinoma in situ, we said it is prognostic. So we always again remember the invasive and the in situ, lobular ductal and ductal carcinoma in situ. Why is that? Because both will need local management, local control, mastectomy, lumpectomy, radiotherapy, you name it. But for the nose, you always need assessment of the nose in an invasive lesion. But in situ carcinoma, DCIS, it has rules whether you need to sample the axilla or not. Again, systemic therapy, yes, invasive, capable of spreading. You need some form of systemic treatment, but you don't usually need it for in situ. So you really, these are the main differences in management. Both need local management. You tend to be more aggressive with ductal carcinoma when you're with your local management. It's an opportunity for cure. Never miss it. Never allow it to come back, because 50% will come back as invasive. Regional systemic, yes, mandatory for invasive, but not so for in situ. So again, strategy, we said local control, regional control, systemic control. What is local control? Since 1976, when Bernard Fisher said, yes, this is the beginning of conservative era, wide local excision and radiotherapy will equal mastectomy. And that was indeed the beginning of breast conservation. We walked away now from William Halsted in 1890 when he was doing radical mastectomy, modified radical PAT, modified PAT, you name it. But now, yes, the rule is to try to conserve this breast. So wide local excision and radiotherapy will always equal mastectomy, and survival is pretty much the same. We talked about trials, the NSPBP 004 from some 40 years ago, proving that it's pretty much the same. But for DCIS specifically, you need 2 millimeter margin. But for invasive, not at the ink margin is good enough for invasive carcinoma, but insist on 2 millimeter margin for the DCIS. Of course, we moved also to what about focal involvement? If I can see it only in one slide, but 1 or 2 cells there, it's called the focal involvement. Do you really need to go back and re-excise it, either DCIS or invasive? Well, I don't. And many of my colleagues, I'm sure, now they say focal involvement, you might accept it. But the rule for teaching is 2 millimeter DCIS, not at the ink margin for invasive carcinoma. Again, what is regional control? We said for the lymph node, it tells you the behavior of the tumor. Did it try to spread? Is it in the, how am I going to do it? Will I be able to check the cells in the blood? It is difficult, and they did it in the past to try to get some bone marrow infiltrate and study the cells over there. But no, we have the axilla. If it is in the axilla, it could well have been in the blood. So the axilla is accessible. We said pre-operatively, you have to do full assessment of the axilla with an ultrasound scan, and any abnormal looking nodes have to have a fine needle aspirate or even a core biopsy. You really need to know that in advance. So when we talk regional management here, we need to assess, we need to know the behavior of the tumor. You either do nothing at all, or you do a sentinel node biopsy, sampling. If you don't have facility at all, you might need to learn from someone about the axillary sampling, but ideally always be guided with like a sentinel node. You can do axillary clearance, level 1, 2. Do we really need to do level 3? We can talk about these things later. But certainly level 3 is obsolete and it's very dangerous. I do it once in a while just for teaching and demonstration, but it is not a good practice to do level 3 unless you are very, very expert and the axilla is just one big mass and you are capable of removing it all. Otherwise, just take a biopsy from that axilla and get out, because you can kill a patient on the table. But level 1, or what I call it 1.5, because level 2 is always a couple of nodes behind the picturized minor, and whenever you pull level 1 out, they almost always say hello to you and come out with you. So I've always over the years said I do 1.5, level 1.5. Right, what about systemic control? How can we protect the body? We need to get information about the risks and the benefit here of having some form of systemic control. What is systemic control? We always think it is just chemotherapy. No, it is not. We have the chemotherapy, we have the hormone therapy, we have the anti-HER2, the Herceptin, the Perjeta, the monoclonal antibodies, and about 20-25% of tumors will be HER2 positive. And for the hormone therapy, we have about 70-75% of tumors would be hormone positive. Zoledronic acid, when you have a patient who osteoporotic, you might be giving the patient aromatase inhibitor, inducing osteoporosis, so zoledronic acid will help you a lot. You might have a patient with bone metastasis, and you treat these bone metastases to stabilize it. It reduces pain, and it has anti-cancer properties as well. So it's not all just chemotherapy. We have chemotherapy, hormone therapy, anti-HER2, and the bisphosphonate. And you can use it upfront before treatment. It's called the neoadjuvant. If you think there's no metastasis and you're giving chemotherapy upfront with a curative intent, you will call it a neoadjuvant, whether it's chemotherapy or hormone therapy or HER2 or anti-HER2. But if you do the operation and you do it after to complement your surgery, you call it adjuvant, again with a curative intent. But whether it's from the very beginning or later, and you have a patient who has metastases, you might still treat with systemic, you will treat with systemic therapy, but in this case, just correct wording is palliative, even if you give it before any surgical intervention. So let's go back to local control. Surgery, we said wide local excision radiotherapy equals mastectomy. So what surgery? What are the indications for mastectomy? The rule nowadays is to try to conserve that breast, but we have situations where you cannot conserve that breast. And this indication, we'll touch it in a minute. And we'll talk a touch about oncoplasty. And oncoplasty is not all about reconstruction. It's all about being a very aggressive surgeon, trying to get a very wide margin, still leaving the patient with a pretty good cosmetic outcome, sometimes even better than before the operation, which has significant impact on the patient morale. Right, so conservation is the rule, wide local excision. We sometimes like to call it lumpectomy, quadrantectomy, or central excision, whatever it is. It is basically WLE, wide local excision with a clear margin. Name it whatever you like, quadrantectomy, lumpectomy, central quadrantectomy, all are pretty much the same. But the indications here for mastectomy, where you cannot do conservation, when you have inflammatory breast cancer, that's horrible. When you have inflammatory breast cancer, it calls for urgent staging, it calls for urgent neoadjuvant chemotherapy. You cannot conserve that breast, don't do sentinel node, and you will need radiotherapy post-mastectomy, and please don't try reconstruction in them, and you will need post-mastectomy radiotherapy for them. So please, inflammatory breast cancer is a no, 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 no. Just go straight for staging, straight chemotherapy, mastectomy, radiotherapy after, clearance, no sentinel node, no reconstruction, please. It's a very aggressive disease. Survival is about 34% over the next 10 years or so. Be very aggressive with it. So it's an absolute indication for mastectomy, inflammatory breast cancer. Multicentricity is very relative. Actually, I don't insist on it anymore in the last 5 years. If I can leave a breast that looks good, and I mark these multicentric lesions well, I have a good sized breast, I have a good ptosis to allow me to do some oncoplastic work, I do conserve multicentric. But for anyone who's a bit younger than me, who's been still black, please go for mastectomy. A patient wish. You might get a young lady with a very small tumor, good sized breast, and she insists on mastectomy. And I've seen that even in England a lot. So it's a patient wish. This has nothing to do with the culture or age of the patient. So yes, respect the patient wish. When you have a recurrent disease, previously irradiated breast, and then you get a recurrent, then you cannot really conserve that breast. We've conserved it in a very old lady, maybe, but the rule is please, it's a mastectomy if it is a recurrent disease. Again, observe the tumor to breast ratio. And if the tumor is big for the size of the breast, then of course you have to go for a mastectomy unless you decide to go for neoadjuvant therapy. Chronic obstructive airway disease and people with systemic lupus erythematosus, connective tissue disorders. If you talk with a rheumatologist before you start their management, he really will tell you, please do a mastectomy. We're worried about radiotherapy in them. And certainly, if I have a patient with a bad chest, I tend to do more mastectomy than breast conservation to save their lung function. Whenever you talk to a medical oncology or radiation oncologist and tell you, no, no, that doesn't affect their lungs, it does affect their lung. But again, it is a relative indication. And whenever you have a patient with connective tissue disorder, please discuss with his or her rheumatologist before you start the treatment. And always offer reconstruction if it is reasonable. So indication for mastectomy, inflammatory, multicentricity, patient with recurrent disease, large tumor to breast ratio, and chronic obstructive airway disease or connective tissue disorder. These are either relative or absolute indication for mastectomy. Otherwise, the rule is to try to conserve their breast. And I'm glad Dr. Ali Nafisa joined us, and I've always wanted to talk to her. So I've seen your photo, Dr. Ali. So, right, go back to my lecture. Always offer post-mastectomy radiotherapy in certain situations. If you have a positive margin, I've done a mastectomy for a DCIS, I've done immediate implant reconstruction or expander or whatever, and I was told that the posterior margin for a DCIS was positive. What am I going to do now? This is one of the indications for post-mastectomy radiotherapy. If you have a tumor that's T3 more than 5 centimeters, I consider it indication for radiotherapy, post-mastectomy I'm talking, and T4 tumors, fixed tumors whether to the muscle or the skin, I consider it indication for post-mastectomy radiotherapy. Lymph nodes call for post-mastectomy radiotherapy. In the past, and you would remember, we used to talk about 4 or more lymph nodes, but for the last 10, 11 years, any number of nodes positive after a mastectomy, it calls for post-mastectomy radiotherapy. So we surgeons need to know these principles. Right. When you have a patient who is requesting prophylactic mastectomy, what can you do with them? I get these questions a lot. I got it from Iraq recently. I got it from colleagues in Egypt a few days ago. Any patient who has had breast cancer in one side has the right to ask for prophylactic contralateral mastectomy, but you need proper counseling. You need to consider her initial disease, the survival statistics from her original disease, her general medical condition, her psychiatric condition. You really need to assess these, but it is her right. And you don't have to get a psychiatric opinion here. It is her right. When we say a patient, young patient with breast cancer poses a risk for her sister, what about her other half? So she had the right without you getting the opinion of a psychiatrist. But again, what about Angelina Jolie phenomena? You have a patient with strong family history, she is tested BRCA positive, and she had the right to request prophylactic mastectomy with immediate reconstruction. But you really need to counsel them very well, get primary counseling, genetic counseling, and then, yes, she had the right to request prophylactic mastectomy. But recently, I had one of my colleagues in Egypt talk to me about a patient who has a strong family history of breast cancer, and she wants to have, and she's very young in her 20s, and she wants to have bilateral mastectomy. What's your family history, young lady? Well, 2 cousins. Is it good enough for her to be offered mastectomy? I say no, please. Oncoplasty, we just touched on oncoplasty. People are living longer, expectations are much higher, disease-free survival improved because of the chemotherapy upfront, radiotherapy, hormone therapy, lots of advances that prolong patients' survival. Again, I tend to do a lot of, for any patient under 30, I tend to do more mastectomy than conservation for them. That's not a rule, that's my rule. So reconstruction is taken really in, and we do it more and more. So oncoplasty is not a fancy work. It's actually to make you a very aggressive surgeon. When you are an aggressive surgeon, that's good for the good of the patient. The margin instead of 1 millimeter, because one of the drawbacks of breast conservation from Bernard Fisher, from Holstead to Bernard Fisher, is increased local recurrence. But now you can do oncoplasty, you get much bigger margins, and you avoid this deformity from the conservation, and in the meantime, you reduce significantly the local recurrence. So it's really allowing us more and more to become aggressive surgeons. We use principles applied by the plastic surgeons to serve us. And just, you don't want to leave some of your patients like that. I will remove it before the Facebook cut us off. And again, this is a patient fairly young, in her 30s, neck. And she always told me, I feel whenever I go to sleep that I will wake up and this tumor is strangling me. And she really was petrified. Systemically, she was fine. So this patient, I actually did it. She died maybe a year or a year and a half later, but she survived without the threat of fungation and ulceration, as you can see that from the shiny skin. And we just patched her with an LD. It's a massive defect, and I was dissecting it off the jugulars of her neck. So it helps you become very aggressive. Again, this is another lady, 72 years old lady, with a horrible tumor, as if a lion had bitten her up. And it's infected, smelly, bleeding, pus. Her family deserted her because of this situation. Do you really want her to stay at home and die in this situation? No, oncoplasty helps you to remove that tumor and patch it with a nearby flap. And the patient, she prayed for my father when she saw next morning that there is no visible tumor anymore. So yes, it allows you to become a very aggressive surgeon. This is the principle of oncoplasty. Timing of reconstruction here, you do immediate reconstruction or delayed reconstruction, or what we call it the immediate delayed. You have a patient, you know, when you do immediate reconstruction, you're not sure whether she's going to have radiotherapy or not. So people aim at the immediate delayed, or we call it delayed immediate, where you can put an expander, preserve the envelope, maybe as early as a week or two when you have the final histology, or later, 6-7 months or a year later, when you have finished radiotherapy, to change it from just an expander to a full reconstruction. So you have the immediate delayed and immediate delayed. 1 stage or 2 stage, you put an expander, change it to implant or direct to implant or straight flap. that's all. We can talk about it, or Dr. Farid can join us and give us a lecture in the future, inshallah. He's an expert. Types of mastectomy. When you're doing reconstruction, you can do subcutaneous mastectomy, just like a standard elliptical incision. You remove the nipple or that ellipse, just like a standard mastectomy, and put an expander or whatever flap you want. That's called the subcutaneous mastectomy, or the skin sparing mastectomy, where you just remove the nipple areola, and then method of reconstruction you're doing, flap, free flap, or an implant or an expander, or you can even, in certain situations, in a good hand, you do nipple sparing mastectomy with whatever reconstruction you want to do after that. But it's not all about reconstruction. I just want to say here, by just observing the lines of your incision, the direction of your incision, that's the most important step in oncoplasty. Uh, you remember from the Langer's line that it was all circumferential incisions, but we know now that circumferential incisions are not always the best. And we have that lazy S, where you get anterior axillary line and straight over the tumor toward the nipple, and that avoids shifting the nipple to the left, and it allows you good access to the axilla, the breast tumor, without changing the meridian, the position of the nipple. You have the vertical radial scars at the bottom half of the breast. They are very good. Again, once you move to the lower half of the breast, circumferential are not the best. Try not to cross the bra line of a lady with your incision, because she wants to wear a bikini, she wants to be comfortable at home, at a party. Certainly don't give her any scars outside the bra line, please. So actually, that's the most important to me about oncoplasty, is observing the lines. Again, as you can see, circumferential incision here. By the time you do excision, blah, 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 and you find the nipple shifted to the left. So we don't like circumferential incisions on the lower half of the breast. While if you did it in lazy S and you close it, the nipple would never change her position at the meridian there, and it added your axillary incision to the breast incision, made you comfortable at both ends. And when you start closing, close from lateral, still a bit of fat from lateral part here into the breast. And I find it extremely useful approach, the lazy S incision, whether it's on the right or reverse S on the left. Again, we all know the racket incisions, where you can centralize or symmetralize the areola. Again, you do that incision, the nipple shifts lateral, you can do that circumareolar deepithelialization and adjust the nipple at the same sitting. They are very important for the patient. But more importantly, I just put this drawing by hand. Here's a pectoralis major, for instance. Whenever you close the breast, please close the deepest parts of the breast tissue above the pectoralis major. If you don't, the skin has an affinity to go down and get glued to the pectoralis major here after radiotherapy and give you that horrible deformity. So just make sure you close the breast parenchyma. And if you can't do all the layers, the deepest layers have to be thoroughly closed. Don't ever allow the skin to see the muscle. Get breast tissue between the skin and the pectoralis major, so you avoid that horrible deformity after radiotherapy. So close it just like this, and trust me, you're not going to get that deep. So this is the oncoplasty, just basic for every one of us. Again, you have to observe here that what possibly will be the difference between a general breast surgeon and oncoplastic breast surgeon, that we do observe. When you have a patient, you see where the tumor is, you observe the distance between the suprasternal notch and the nipple. Both nipples have to be almost where the meeting point of the visibly with the breast level with the inframammary crease, about 18 to 20 centimeters from the suprasternal notch. So when you see a patient with the nipple down there, about 25 centimeters there, and tumor above the nipple between 18 to 22 or so, you can always do some oncoplastic approaches, whether it is S or bat wing or many other approaches. We're going to talk about it later. So it's just observe not just where the tumor is, the size of the breast, the degree of ptosis of the breast, and that will open ideas, will give you so many ideas about what is the best approach for this patient to avoid any cosmetic unpleasant result, but also to get a very good clearance of the tumors. We have about 40, no, about 60, 70% of tumors will, when they are multifocal, they will be in the upper half, and you have a good degree of ptosis. You noticed it in your clinic. You can actually do a lot of fancy work without having to do a mastectomy for these cases. So observe these landmarks. The distance between the suprasternal notch and the nipple should be about 18 to 20 centimeters from midline to inner aspect of the areola at 9, outer aspect of areola to anterior axillary line 11 centimeters, from nipple down to inframammary crease 7 to 10 centimeters. Observe these points. You have a patient here, it's 18 centimeters there, but there is a ptosis about maybe 7 or more centimeters, and you have a tumor here. It is very feasible to do a bat wing. If you're not very comfortable, you can do a bat wing incision, and the nipple will be lifted up there, and that will be straight line here and there, and you got a very good clearance. And because the nipple was much lower than that 18 centimeter, it had good ptosis, it allowed you to do this oncoplastic approach. Again, you have a tumor that's good degree of ptosis here, and you have the tumor half there, and you can do that lazy S, which I love it, and I'm going to show some pictures of it. And I actually use it a lot, this beautiful S incision, and fantastic, especially for multifocal disease in the upper half. You can get with a good degree of ptosis. Observe the ptosis, please. This is one of my patients. She had a massive tumor. It's a massive tumor, and she doesn't want to have mastectomy. She had not a very big breast, but good degree of ptosis. We removed a huge tumor from her, about 14, 15 centimeter tumor. And there you are, a week after the operation. And after radiotherapy, it's a very good conserved breast. I had recently 24 years old patient. She's going to get married in a week or so. It's a massive tumor there, and that was she has a small breast, but it's a massive tumor. She left it so many years. She was always told it's a fibroadenoma, leave it alone. And then we removed it, the same S incision. It's about 17 centimeter tumor, and she's very delighted with the cosmetic outcome. So just observe the ptosis of the patient, and that will give you a lot of ideas about oncoplastic techniques. But it's not the topic today. I'm just talking about local control, wide local excision, and radiotherapy equals mastectomy. What is wide local excision? This size 2 millimeter, not a think margin for invasive, and just observe the oncoplastic opportunities here. Be an opportunist to become a very aggressive surgeon. Regional control, that's a talk, I think, talk everywhere, every day we talk about it, lymph nodes, because what we say a week ago might totally be different from today. It's just changing from day to day, the talk of lymph nodes. But we go back to a little story. We used to do clearance from the times of William Halsted, but 70% of tumors, nodes removed, would be negative. But we have a 30% chance of having lymphedema. So we try to find out which is lymph node negative, and can we save them from having clearance unnecessarily and avoiding the risk of lymphedema. So I did a lot of work from 1976 at the time of Bernard Fisher until we reached to what we are doing today. And possibly today will be different from next week. So we do a sentinel node or nothing at all. Node sampling, we do axillary clearance, we do level 1 to 2. When we do sentinel node and you find it positive, do we proceed to clearance or not? Or not nodal surgery at all? We'll touch it in a minute. Please You need proper assessment of the axilla. Insist on proper assessment of the axilla before you plan hard management. Ultrasound, if there's any abnormal looking lymph nodes, FNA is mandatory. If you find that the FNA is positive, then you know it is positive, but it's not a good negative. So if it is negative, you have to still do some surgical assessment of the axilla, which will be the sentinel node. But if it proved from the very beginning, it is a positive axilla on PET-CT scan, on FNA, or assessment of the axilla, then it is an easy decision. You proceed to axillary clearance with your primary surgery, unless you decide not to touch the axilla at all, like in certain situations in very old ladies. We'll not talk about it now. But if it is clinically negative, ultrasound, normal axilla, abnormal node, FNA, negative, still, all these are clinically negative axilla, you do sentinel node. Whether you're going to do an intraoperative assessment of this lymph node or just sentinel node, no frozen section, and then see what things are later, that's what I do. If it is clinically negative axilla, with ultrasound, with an FNA, and clinically as well not matted axilla, blah, 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 I do sentinel node. I do not proceed to clearance on that setting. I do not do frozen section. Intraoperative node analysis, I still consider it obsolete. I might be hammered from some people when I say that, but I still consider it obsolete. We all know the Z11 and we know the amorous axillary mapping radiation or surgery, which compared what further management. We'll touch it in a minute. Right. But for ductal carcinoma in situ, you don't need to touch the axillary nodes unless you are doing mastectomy, because there is a high chance here, as much as 6% of node positivity. And if you did a mastectomy and you find invasive disease, you will not be able to do sentinel node because there is no breast tissue to inject. So whenever you're doing mastectomy for a DCIS, it's mandatory to do a sentinel node assessment of them. If DCIS patient presented as a lump, because there is a good chance here that it has already developed an invasive component. And so you do a sentinel node. Some people consider choroidal necrosis high grade is an indication for a sentinel node, but it's not my practice. I do a sentinel node for DCIS, for mastectomy, and if it did present as a lump. But if it is invasive cancer, again, we said preoperative assessment, sentinel node, minimal surgery is the main lesion. It used to be some contraindication for sentinel node in the past. The main absolute contraindication is inflammatory breast cancer. The ones we say T4 or multifocal diseases cannot have sentinel node, or post-neoadjuvant cannot have sentinel node. It's not anymore. We now all have become expert on it. And the only absolute contraindication that I know of for sentinel node biopsy is if it proved positive or for inflammatory breast cancer. Ideally, you should use technetium and blue dye, both of them, dual technique. But I think only 2 centers in the whole of Egypt have the facility for technetium. So blue dye is available. It's fairly cheap. It costs for a 4 milliliter patent blue. We used to get it in England 2 milliliters, but now in Egypt we have it either 2 milliliter or 5 milliliter pre-packed syringes, and fairly available now and handy. It's about £400 for a 5 milliliter syringe and £300 for a 2 milliliter syringe. No excuse now for not using blue dye and doing sentinel node with it. The Scottish were very keen on doing sampling without any blue dye. You do it, but it is still not recommended. But yes, you can do it if someone trains you how to do it. And always get the hot, the blue, but even if it is not hot and blue, but large and hard, you also have to remove it with your sentinel node. Offer axillary node dissection, or if preoperative assessment showed nodal involvement, then there is no sentinel node here. It is mandatory for inflammatory breast cancer to clear the axilla, no sentinel node. If a patient has had neoadjuvant chemotherapy, it used to be absolute indication, absolute contraindication to doing sentinel node, but not anymore. We have had studies from Germany, the Sentinella, many others, and there are some studies now, like I think the Alliance is going on to address this. We used about 10 or more than 10 years ago, we used to do sentinel node before we start the neoadjuvant chemotherapy, but we don't do that anymore. In specialized units now, yes, and if you are an expert, you can do sentinel node after neoadjuvant chemotherapy. But we can talk hours and hours about it, but we need excellent assessment of the axilla pre-treatment. During the treatment, you can put a clip, a marker clip. You do an ultrasound assessment after you finish treatment, before you go in for the planned surgery, to try to detect a certain the nodes that were previously positive, and they have that marker inserted in them, the magnet, whatever you use. And if you can't, then just proceed to clearance. But if you decided to do sentinel node and the circumstances allow you after neoadjuvant chemotherapy, please make sure you remove minimum 3 nodes, up to 5 nodes or even more, to reduce the false negative and improve the correct identification of the lymph nodes. All patients should be informed of the risk of lymphedema. We once in a while get that situation where you have a patient with nodal disease, but you cannot identify the primary in her breast. You do a lymph node biopsy, it is metastatic from breast, it's ER positive, PR positive, HER2 negative, or HER2 positive. You do a CT staging of the whole body, and you cannot identify a source of her nodal disease. You get an MRI of the breast, and still you cannot identify a source. What are you going to do? That occult disease. And mastectomy and axillary clearance followed by chemotherapy and radiotherapy is the best result, but you can discuss with the patient. I can do a axillary clearance and leave her breast alone, provided you irradiate it. It's an interesting topic, and we can talk about it at other time, but I just thought I would mention it. Right, if you have the sentinel node positive, should you proceed to further treatment of the axilla or not? The wording of the Z11 said, if you have up to 2 lymph nodes positive and you're planning breast conservation, patient going to have radiotherapy and some form of systemic therapy later, and no extracapsular invasion, up to 2 millimeter micro disease in the lymph nodes. Should you proceed to further treatment of the axilla? They never said clearly, they said treatment of the axilla or not. Then Amarus came and tried to answer it after mapping of axilla, radiation, or surgery, and actually found that radiotherapy in these situations is as good as, if not better, than further axillary clearance. But there are still in UK, I know there are some studies going on now to further address this point. But for me, for my personal practice, if it is clinically negative axilla, I do sentinel node. If I have up to 2 lymph node positive, no extracapsular invasion, I recommend radiotherapy to the breast and axilla. I don't take them back to theater, and I don't do further section. But you can argue as much as you like. Just for information, when you do a lymph node biopsy, you can find isolated cancer cells, and we consider it a node negative. Tumor up to 2 millimeters, we call it micrometastasis. And if it is more than 2 millimeters, you call it macrometastasis. Please, on your pathology request, it is very important, because you really have to have the pathology up to scratch, and the radiologist, because you are as good as the radiologist and pathologist working with you. So insist, nag the radiologist to give you proper assessment of everything, nag the pathologist to really give you the correct information. It is not very nice to get an information telling you free margin. I'm sorry, what do you mean by free margin? What is the closest margin in millimeters, doctor? Nothing called free margin. And you have to correctly mark the specimen, whether you use the short suture, superior, long lateral, whatever you plan for yourself. You like to use clips, you like to color it yourself in theater. Just make sure you well orientate the specimen, communicate thoroughly with the pathologist, put it informally as soon as is possible before you get any receptor degradation, which can, unfortunately, I have seen it, left hours and hours outside the formalin. You should write on your request to the pathologist thorough history, whether she's had previous treatment or not, your marking, and insist on hearing about the actual size of the tumor, the margins, nothing called free margin. What is the margin in millimeter, the correct grading, DCIS or not, the percentage of it, lymphovascular invasion, the number of nodes involved, the size of the lymph nodal involvement, because we still get reports telling you 3 nodes involved, 2 nodes involved, 1 node involved. I'm sorry. What about the extracapsular invasion? What about the actual size of that nodal metastasis, not just the number? Whenever you nag your pathologist, you will get them to your standard for the good of our patients. Hormone receptors, we say 70-75% will be ER positive, and 5% actually will be ER negative. Yes, they are still PR positive, treated as ER positive. But again, we doubt it, but we still treat them as, although we give them hormone, but we consider them negative. HER2 status, human epidermal growth factor receptor gene, is very important to know it. The Ki67 is not helpful all the time. If you already have an ER negative, a HER2 positive disease, a null positive disease, Ki67 here will make absolutely no difference to you whatsoever. But we're talking about cost-effective era, and you request unnecessary tests sometimes that will not add much to the management of a patient, but will cost them a bit or a lot for them. Might not be necessary if you've got enough biomarkers. Oncotype DX for a borderline case, shall I give her chemo or not? The Oncotype DX problem with it is that, again, it will tell you 0 to 18, 18 to 30, more than 30. Yes, give. Most of them back as it's still in the just a bit, but it is one of the tools, the Oncotype DX. The DCIS, you can always assess the ER to determine whether you want to give them a hormone therapy or not. Yes, you can request the ER on DCIS, but it is sad that we see people requesting HER2 on a DCIS. It's ridiculous, so much cost to the patient, and you don't need to test it because you are not going to use it and will always be positive. Right, so again, remember the strategy, we'll go back to it. We talked about the local control, we talked about the regional control, we finished with the sentinel node. Now we're talking about how to plan systemic control. Does it matter to you as a surgeon? Yes, it does matter to know from the very beginning whether this patient will need systemic therapy or not, because it will make a difference to the type of management that you're going to carry out for this patient. Adjuvant therapy is either systemic therapy or radiotherapy. We agreed that who will have radiotherapy? Any conserved breast will have to have radiotherapy. Again, in extremely rare situations, you don't, but yes, for almost 99.9% of the patient, any conservation will call for radiotherapy. Post-mastectomy, if you have a positive margin, you did a mastectomy, DCIS, you've done a reconstruction, told you a positive margin, what you're going to do? Radiotherapy, T3, 5 centimeter tumor, T4, fixed tumors, any number of positive nodes. Once we said 4 nodes or more give radiotherapy, but not anymore. It's even a single node positive calls for radiotherapy to after mastectomy. Right, for a DCIS, you remember that Van Nuys. I like Van Nuys very much. And whenever you talk to your colleagues, talk to the clinical oncologist, medical oncologist, and say, oh, we don't believe in Van Nuys, but actually, you will discover that we always follow it, right? So you look at 4 parameters of the DCIS: the size of the tumor, the grade, the margin, and the age of the patient. The old one used to be we never talked about the age, but with a South Carolina modification, they consider the age of the patient and they give a score. And if it is 4, 5, 6, no further action, just lumpectomy, but 7, 8, 9 radiotherapy. And if it is 10 or more, please go and do completion mastectomy. That's a nice thing, but actually we say we don't follow it, but in reality, if you follow your practice, you will find that you almost always follow it subconsciously. Right? Systemic therapy, again, we talked about them, but hang on, let's talk here upfront: neoadjuvant, adjuvant, palliative, hormone therapy, we talked about it. What sort of hormone therapy? The tamoxifen, it works for any age because it's a competitive inhibitor, and 20 milligram daily for a premenopausal or postmenopausal, but aromatase inhibitor only for postmenopausal because it only blocks the transformation of androgens into estrogen by the aromatization in the subcutaneous tissue and the muscle. So the patient has to, the ovaries have to be off to be able to use the aromatase inhibitor. Again, hormone therapy, we have done ovarian ablation like ovarectomy, radiotherapy, or temporary paralyzing that ovary by LHRH Zolidix injections monthly or 3 monthly. You transform the patient into postmenopausal status so you can use aromatase inhibitor, and it's more and more in practice nowadays, this approach. Never give hormone at the same time with chemotherapy because they are against each other. Whenever you plan anything, it's chemotherapy first. Could be same with radiation and Herceptin, the hormone therapy, but never at the same time with chemotherapy. Tamoxifen for any age, aromatase inhibitors only for postmenopausal. It is 5 years compulsory and 10 and 5 more years. More and more we are using it. I say to my patient, 5 years compulsory and 5 more years voluntary. Who needs chemotherapy? How can we plan it? For you as a surgeon, you need to be, while you are in the clinic, to predict whether you need to call the medical oncologist. I know we all have the MDT in many parts of course, all over England and some hospital centers in Egypt, but not we don't all have MDTs in our private clinics. So you need, as a surgeon, to predict who might need chemotherapy. Shall I ask a medical oncologist to see the patient first before I plan any surgery? So you really need to know some predictions here, right? So we have the Predict NHS. I don't know whether Farid uses it or not, but I find it's nice if I, and you have adjuvant online, but it never took into consideration the HER2 status. Nottingham Prognostic Index of 1987, but never took into consideration neither HER2 ولا حتى الهرمone receptors. It's fun to have to know the NPI, but we don't use it. But predict if you want to get markers. But I always say, I've said it for the last 15 years, I have 6 markers, and I'm glad the NHS predict exactly take these 6 parameters. I've always said to my colleagues, if you have 2 of these parameters when you see a patient in your clinic before you plan surgery, she is likely to need chemotherapy, and you might get the help, advice of a medical oncologist before you start her treatment. And what are these 6 risk factors? The premenopausal is one risk, tumor more than 2 centimeters, grade 3, non-positive, ER positive. Any two of them in any, and if you have three or more, the benefit will be 8 to 10%. And the more points of these six you have, the more likely benefit from chemotherapy. So observe these points. So if I have a patient in my clinic, she's 32, premenopausal, her tumor 3 centimeters is grade 3, and that's it. Before I know the nodal status or the receptor status, I know she will benefit from chemotherapy. Now, my question will be, should I give it before or after? And then you start to see the benefit from having neoadjuvant. Will it help me, instead of doing mastectomy, to conservation? Will it help transform the axilla from positive to negative so I can save her clearance? But you only need to know this, to know from the very beginning the likelihood of patient before you touch her that she might benefit from chemotherapy, then get the opinion and support of a medical oncologist. Timing of adjuvant therapy, it is recommended that always adjuvant therapy start within 40 days or 35 days from the step before. So if you did an operation today, try please to start the next step, whether it's chemotherapy or radiation, within 35 to 40 days. The priorities, if you need chemo, radio, hormone, the priority is chemotherapy first, and then go back to radiotherapy. But remember, radiotherapy ideally should be given within 6 months from surgery to get the best benefit from. There are studies saying up to 7 months, but still you need to do chemotherapy and then move on to radiotherapy and hormone therapy. Please, no staging before diagnosis. We see it a lot. Patient coming with 2 centimeter tumor. Before we even get the core biopsy results, you get the patient coming with having had a PET CT scan, and then the core biopsy proves DCIS. It's absolute waste of resources for these patients. You don't need to stage any tumor less than 5 centimeter, node negative disease. CT scan in today's practice with a good software is more informative about bone metastases more than a bone scan. I only request a bone scan if the CT scan showed metastases in a vertebrae or a rib or sternum or pelvis. You will never ever get a long bone metastasis in a patient that spared the sternum, the vertebrae, the pelvis, the ribs. Absolutely not. So if you CT scan shows metastasis, fair enough. Now I need a bone scan to see the skull and to see the tip, or you go for a PET CT scan from the very beginning. I hope I covered a lot, and thank you very much. And Allahumma allimna ma yanfa'na wa anfa'na bima 'allamtana. Thank you very much all, and let's have the floor open for discussion.
Anyone has a question? Please unmute. So, Dr.
Can I ask a question?
Of course, of course. This is Dr. Nafisa.
Yeah. Assalamu alaikum.
I follow you a lot. I follow all your good work, Nafisa.
Thank you, sir. I'm from Bangladesh and student of your student, Dr. Farid Ahmed. I like to add on thing that breast lump, actually in Bangladesh, one of the causes granulomatous mastitis, you know, that tubercular mastitis. It is
Okay.
sometimes we confused about the tubercular breast lump carcinoma. We have to confirm this is tubercular granulomatous mastitis by core biopsy. So I want to just add this. Thank you.
And did you diagnose it on microbiology?
Yeah, actually sometimes granulomatous mastitis come with lump. You know that tubercular TB is a cold abscess, right? So no pain, only lump, and it will mimic with the carcinoma. Sometimes the secondary infection super added with it, then it is come as like abscess. So when it is cold abscess and no secondary infection, it confused about with the breast carcinoma.
We do see it a lot in Egypt, presenting as lumps, but usually multiple lumps, very lobulated lumps, and quite often have red patches over them with a bit of sterile pus coming from them as well. So interesting that we should culture as well for resistant cases for TB.
Yeah, we have to do core biopsy and confirm histopathologically that it is the breast TB. And then after excision of this lump, we have to add anti-tubercular therapy for 9 months. And so in that under the guidance of Dr. S.K. Farid Ahmed, we now use the ADM, acellular diamond matrix for breast reconstruction, immediate breast reconstruction. I add
well,
this.
You must be a very rich country. You must be very rich people.
No, actually, not too much rich people, but in Bangladesh, you know that lots of people travel abroad for the better treatment. So we actually try to keep this up our management protocol up to the UK protocol, and we have hydromark. You know that best biosite marker hydromark for before the neoadjuvant chemotherapy. We have also, and we have wire also.
Yeah, I'm following all the good work of Dr. Ahmed.
Yeah,
I follow all his good work there. But I will just say, please, for granulomatous mastitis, surgery, refrain from it. We really don't respond to medical treatment. Please don't operate lightly on granulomatous mastitis. Their wounds do not heal very well. I treat them with high doses of steroids. They respond very well. Once you opened it, you superimpose it with bacteria and becomes very messy. And I only ever operate on them if they completely disappear, except a very small lump, a very small, less than 2 centimeter lump. But otherwise, my rule is please do not operate on granulomatous mastitis if you can.
Is it idiopathic granulomatous mastitis or tubercular granulomatous mastitis?
No, we don't have tuberculous granulomatous disease in Egypt.
Oh, actually, idiopathic granulomatous mastitis is a response well to the steroid, but you know that tubercular granulomatous mastitis need to operate first, otherwise the tubercular drug do not work properly.
Well, I treat about maybe 50 or more a year here in Egypt, and they all respond to medical treatment, just steroids, and so they could disappear within 5 weeks. Some take up to 6 months. I've possibly over the last year operated only on one out of these 50, and they come to me sometimes having had surgery, but by one of my colleagues, and they come in a mess.
Actually, thank you.
Okay. Good to talk to you.
Ashraf, السلام عليكم دكتور أشرف.
السلام عليكم ورحمة الله.
الو دكتور أشرف. أخبارك يا باشا عامل إيه؟ بالنسبة للرول اوف فاين نيدل اسبيريشن and axillary lymph node, is it 100% sure?
It is good positive, but not 100% negative. So it's almost 100% positive, but if it is negative, you still doubt it. But if it is positive, it is positive.
We have two questions.
If it is positive, it's positive, yeah.
It's a good, I would say it is good positive, but not good negative.
Yeah. So we can't do true cut for the lymph node if it's sizable.
Yeah, exactly. It is how brave your and how expert your radiologist is. لو الراديولوجيست ماهر وهي بعيدة فعلا عن الفين وكبيرة يقدر ياخد لك منها كور بايوبسي طبعا. لكن لو شاب أو شابة صغيرة, young people not comfortable with the axilla, they will not take a core biopsy from it. So it depends on your radiologist. Yeah, لو lymph node accessible with a good radiologist, they can take a core biopsy from this. But if they are not very comfortable, they will just rely on FNA.
اوكي.
Yeah.
عندنا سؤال
ايوه
من دكتور محمد
ايوه
حمدي. دكتور احمد قط.
ايوه نعم.
اتفضل يا دكتور.
السلام عليكم دكتور أحمد.
السلام عليكم. اهلا دكتور اشرف. Thanks for this. الله يبارك فيك. Thanks for this marvelous presentation.
I thought we had a vision. Yeah.
I think there is a missing slide. You in this strategic planning for breast disease management, there is a missing slide about the importance of the multidisciplinary approach and the one-stop clinic.
Yeah. I talked about it in 2 weeks ago in our first lecture, that one-stop clinic, this is how we developed a center in Egypt called Bahia. I had the privilege of having written the vision for them, and we said it's a one-stop clinic. I have to have the medical oncologist on site. I have the mammogram, ultrasound, MRI, CT scan, all under one roof. So the patient comes now, being examined now, just like we do in UK, and have the mammogram, ultrasound now. We communicate with the radiologist on the spot, and any core biopsy will be taken now. 48 hours later, you have the results. So yes, we wish we can have it everywhere. And regarding multidisciplinary, please, there are 3 core people in a multidisciplinary, or let's say 4 core people. It's you as a surgeon, the medical oncologist, radiation oncologist, and the pathologist. And of course, you have the radiologist with you. I talk to my radiologist constantly. Whenever I get a mammogram, I call them. Why did you say this? Why did you say that? How about, can I discuss it with them? And I make sure I'm dealing with a very good radiologist. And for the pathology, actually, when I was praying Fajr today, I was writing to my pathologist about a report she sent to me last night, discussing it with her, and then talk to her on the phone this morning. Why did you say this? So this is talking to them. It's not always possible to have it on site, but at least communicate. And at the era of COVID-19, we all learn to communicate online now. My medical oncologist, I call my medical oncologist with a patient sitting in front of me. If I suspect that we might need medical oncology input beforehand, I call them, I give them all the criteria, the 6 criteria I have, I give them my opinion, and if they want, I send the patient to them. So yes, it's always talk and talk and talk. There was once in our countries, the surgeon was a god, but it's not anymore. We have to work as a team, as you said, Dr. Cobb, medical oncologist, radiation oncologist, radiologist, and pathologist, and Mr. Surgeon. So yes, communication is mandatory, absolutely right. Whether you will have it as an on-site MDT, or you're going to have it online MDT or on phone MDT. Yeah.
Okay, shukran.
Question from Dr. Muhammad Hamdi. I have 2 questions. First, what are the criteria to excise a fibroadenoma? Do we need to get all fibroadenomas out? The other question is, how would we investigate gynecomastia, especially in adolescents?
Okay, right. We talked about the fibroadenoma in the previous session. Fibroadenoma, as we said, you need, you have a patient, you examine her, she's young, you examine her with a lump, a mass, whether she's over 30, you're going to get a mammogram and ultrasound, under 30, you're going to get an ultrasound scan. If with your hand bears all the criteria of being a fibroadenoma, supported by the ultrasound scan, that it is clear-cut fibroadenoma, and the patient under 25 I observe 4 to 6 monthly with repeat ultrasound scan. But if she is over 25, I insist on having a core biopsy. If she's over 25, if she has a strong family history of breast cancer, that's how you investigate it. Now, which one you going to excise as a fibroadenoma? Well, if you have a palpable, not just by ultrasound scan, because it's quite often you get a patient 20, she had a fibroadenoma, clinically palpable by hand, and then you get an ultrasound scan and you will tell you 2 or 3 more here and 2 or 3 more on the contralateral side. You're not going to go after all of them. You might get an MRI in certain situations, but I'm talking about the palpable lump. I'm sure this is your question. Now, I have a palpable lump. When am I going to excise it? It's proven fibroadenoma by just ultrasound and hand under 25, or with a core biopsy if it is more than 25. You set a target for yourself. And I said at the beginning in Harda, every hospital, every country, every surgeon will have a threshold of when to excise it. My threshold is 3 centimeters. Dr. Farid or somebody else might say 5 centimeters or 2 centimeters. So if it is more than 3 centimeters, I do recommend excising. I respect a patient wish, even if it is 2 centimeters. I'm talking about the palpable lumps. 2 centimeters, the patient is petrified. She takes it to bed every night with her, and she's preoccupied with it. Or if she has a family history, or when I see her in 4 to 6 months and I find the lump increased by 50%, it was 2 centimeters, became 3. It was 3, became 4 and 5. Then it is fast growing fibroadenoma, or a patient wish, or whatever size you set always as a target for yourself, or a patient with a palpable lump who has a strong family history of breast cancer. In these situations, I do advise. Now, there is another one here. If you have a fibroadenoma and you are observing and it has not disappeared by the age of 30, they will never, ever disappear. And it will be up to you now. You know that the main risk for developing breast cancer is being a woman and getting older. So the risk of developing breast cancer between 20 to 30 is 1 in 2,000. Between 30 to 40 is 1 in 200, 10 times more than 10 years earlier. And between 40 to 50, it is now 1 in 50. Between 50 to 60 is 1 in 20 or 1 in 24. So as we get older, the risk of a patient developing breast cancer grows. And now we have a benign big lump, 3 centimeters, sitting in the upper outer aspect of the patient's breast. And you're telling her, keep an eye on yourself. If she develops cancer behind it, she's not going to know the difference. In our cultures as well, you get a patient, 3 centimeter lump, she's seen so many doctors, she spends so much money, and then she was told, that's okay, it's benign, leave it alone and live with it. Trust me, she will develop another lump on the contralateral side, and she's not going to come to you because she spent so much and you told her, do nothing. So she will assume this is. And one of my consultants in the UK in the 90s was taken to court because a patient developed cancer next to fibroadenoma that he was observing. So over 30 with a palpable lump, I feel very nervous leaving it. So again, I summarize the answer for you. It's a patient wish, you respect. Set always a threshold, 2 centimeters, 3 centimeters, 4 centimeters, whatever you like. The fast growing, the palpable with a strong family history of breast cancer, and over 30 palpable, consider excising it as well. I hope that answered your question, Doctor.
Yes.
But sometimes we find
Yes.
a patient with fibrocystic disease with multiple breast lumps. I say, oh.
Yeah, fibrocystic is different. Fibrocystic is a different from fibroadenoma. Fibrocystic, you just make sure it is not cancer. It is fibrocystic because if you go into excise fibrocystic, you're going to excise the whole breast.
Yes.
So it's a totally different from fibroadenoma is different. Fibroadenoma is different from fibrocystic.
Yes.
I always describe it as, you know, when you bake a cake, do you ever bake? Right. When you bake and cut your cake, you find Huh?
No, no.
If you cut your cake and you find pieces of air and pieces of syrup and pieces of hard dough and an irregular surface, and if you start to try cutting it and get a clean piece of cake, you will finish the whole cake and you will never get it clean. So fibrocystic is different from fibroadenoma. Fibroadenoma is a big piece, standalone piece. Fibrocystic, you just need a core biopsy, prove it is fibrocystic, and follow her up. But it is totally different from fibroadenoma. It's a different age group even.
Yes. Yes. The other question, how to investigate gynecomastia in adolescents?
Well, possibly I don't see a lot of it, but I used to see a lot of it and operated on many of them in my life. Right. Some people advocate, you examine the patient thoroughly, you examine their breast, you examine them systemically well, you examine their testicles, because there is a certain type of tumors in the testicle called a Leydig cell tumor that is a hormone producing tumor. And I've seen that in my life in a patient called Adam Young. I still remember his name very well. He used to live in Australia and came back to England with a massive gynecomastia. And he was surprised when I said, take your pants off, and examined his testicle. It's a big tumor. And I said, how long has it been like that? He said, well, it's my normal. And that was actually this Leydig cell tumor. So make sure you do a thorough examination, take a drug history. You know that liver diseases can lead to gynecomastia. Certain medications like digoxin, like all the PPIs for stomach ulcers, it depends on the age. There's some physiological at the age of 15 to 20, you do nothing more than just examination. 20 to 30, again, ask about bad habits, drug habits. Cannabis can cause a gynecomastia. Anabolic steroids, you see a guy coming with big muscle there, and then we have a little boob there. And so all anabolic steroids. So take a thorough medical history and drug history, and check the liver function. Some people do recommend thyroid function tests, and just general examination. And you get an ultrasound scan. Sometimes you can get a mammogram if the breast is loose enough to put it on the machine. Always remember the male and female breast before puberty are limited to the areola. But after puberty, the female breast grows outside the areola, but the male breast will continue to be limited to the areola. So when you examine a patient and it has a lump on the breast area, but you can't put her between the nipple and that lump, that cannot be gynecomastia, it cannot be breast tumor, because male breast is limited to the areola and starts to grow. So you cannot get your finger between the outer aspect of the lump and the nipple. If you can't get it, then this is a chest wall lipoma or whatever. So we'll always be limited to expanding from under the areola. You get an ultrasound scan. If they tell you that's a classic gynecomastia, it's diffuse, you do nothing, keep an eye on it. If they are on certain medication, try to change the medication. And sometimes stopping PPI itself is good enough to improve gynecomastia. If it continues to be concern for you, a core biopsy is acceptable investigation. As to management, I don't think anyone can tell you exactly how to manage it. It's a psychological issue for the physiological. Under 20, resist operating, assure them, because it's likely to fade away as they grow. But if it becomes really psychologically upsetting to the patient, you get a stunt actor with big muscles and then big thing here on there, is embarrassing him and he cannot earn his living with this, then you are going to do excision. What technique? It depends on the size. Can I treat it with tamoxifen? In my life, I've treated them a lot with tamoxifen, especially those who affect the older people whose main concern is pain, not cosmetic. Tamoxifen completely takes the pain away. 20 milligram tamoxifen 1 a day for 2 months. I've seen it really clearing their pain. But after correcting the medication, digoxin, please, spironolactone, as we all aware of it, all the PPI, cimetidine, ranitidine, all the Zol family, stop them and they get better.
Yes.
I hope I covered it.
Yes. Yes.
A bit.
Yeah. A lot of messages.
May I supplement something?
Please, Farid, yes.
Thank you, Ashraf. I'm not surprised with your lecture. I mean, 20 years back, you were the best. And after 20 years, you are still the best. In a complex, within a short period of time, you have covered everything about breast disease, including breast cancer, which is simply amazing. Coming back to gynecomastia, I have a particular interest. I've been running a treatment trial with tamoxifen 10 milligram once daily for the last 16 years. And I have a large series. I've got the largest series published in UK. And so far, the evidence suggests that 90% of patients with tamoxifen 10 milligram once daily for 3 to 6 months is sufficient to cure the problem. 10% it doesn't work. But once, what you have already mentioned, once you have covered everything, as you have given very eloquently the pathway, how to manage gynecomastia, I'm talking about the last part. And it really does work. And as you know, for last 16, 17 years, the funding has been taken away by government. We can't operate under a national health service for gynecomastia surgery. In new days, if you remember, you have taught me to do a lot of gynecomastia surgery and different approaches, but it doesn't happen anymore. So we are trying to treat this with tamoxifen with very good success in recent 15, 16 years.
That's interesting.
Thank you.
I'm going to reduce it now to 10 milligram for 3. I used to give 20 for 2 months, but I think now I'm going for 10 for 6 months, as you said, Farid. Yeah.
10 has been, we started with 20 milligram for a year, then we changed it to 10, and almost 15 plus years, 10 milligram. They're all doing great, really.
MashaAllah. Thank you very much. Yeah.
Pleasure. May I allow to say another 30-second few things?
Yeah, of course.
It's simply awesome lecture you have given. You covered everything. I'm not going to say it again. We routinely use Predict as well here, as well alongside Oncotype DX. And every patient gets discussed in MDT, as you know. When it comes to margin surgery, breast conserving surgery, even if it was DCIS or invasive cancer, there was a consensus meeting took place in Association of Breast Surgery UK in London, 2015. I know NICE suggests 2 millimeter, but ABS consensus meeting came out as 1 millimeter sufficient. And for last 5 years, we are practicing 1 millimeter deemed as sufficient for clearing margin, so we don't go back.
Okay. With a boost, of course.
And,
with a boost to the tumor bed.
Yes.
Yeah.
Yes, the boost could be for other reasons as well.
Yeah.
And according to ATOM and ATLAS trial published a couple of years back, tamoxifen is prescribed now 10 years,
Okay.
with few exceptions.
Yeah.
But now we are prescribing tamoxifen for 10 years. And lastly,
whether they are ER or positive or negative?
ER positive, of course.
Yeah.
ER negative is out of question, Ashraf.
Yeah.
The one last thing I would like to say, you must have seen Prime 2 trial outcome a few years back. Patient over 65 who has got early breast cancer with good tumor biology, like T1 or T2, node negative, ER positive, HER2 negative. You can discuss patients avoiding radiotherapy to breast. And in fact, in Thames Valley, we are practicing it kind of routinely in our MDT to discuss this option with the patient. And many patients actually opt not to have radiotherapy for this sort of a smaller group of patients who have got good tumor biology. So I just thought I will share this, what we are currently practicing. But I have to say.
That's my practice. I practice it indeed, Farid, but I try not to say it in public. But yes, I do practice it, yes, for over 65 with a low burden tumor, node negative, strongly RPR positive, HER2 negative, good margin. I'm happy with it. I either give hormone, offer hormone or radiotherapy. You're absolutely right, yes. But, you know, there are things when you teach like driving in England, you have to hold the two and look right and left. But once you have your license, do whatever you like. I'm trying.
I agree. I agree. Thank you very much for allowing me to
I
join and to listen to your
like,
lecture. Brilliant.
and I'm going to use you for an oncoplastic session in the future, inshallah.
It will be my pleasure, my honor in future, inshallah.
We have a lot of thanking messages from the audience, but we have the last question, Dr. May Kamal. If it is a multiple fibroadenoma, what is the management?
I'm unable to answer it, but it will depend on many things: the age of the patient, the family history of the patient, and the size of the breast of this patient. Because I tell you, I believe that fibroadenoma is a proliferative disorder. So is cancer. It is a proliferative disorder. So patients with multiple fibroadenomas are at a higher risk of developing cancer in the future. It is not in the literature, it's not in books, but in practice, it is a proliferative disorder, multiple fibroadenomas. It is unhappy, unsettled breast. So they are always at a higher risk of developing cancer. And if they develop cancer behind one of these palpable lumps, it becomes really difficult to diagnose it at an early stage. So it's really difficult. And if I have a patient, and I've seen it many times. I've seen it in Bahia, I've seen it in Al Fayoum General Hospital some 6-7 years ago, where you get a patient with 10, 15 fibroadenomas in one breast, and similar situation on the other breast. And what you're going to do with her? Bilateral mastectomy and reconstruction is an option. Am I going to go after just all the big ones, or what? If they allow me, I can show, if you have a few more minutes, I will show you a photo. Will you allow me, bosses?
Okay.
Okay, thank you very much. I will just get my, I want to show you a patient, 11 years old. And that 11 years old, she presented with bilateral she's 11 years, presented with bilateral massive breasts. And she was sent to a pediatric surgeon.
Yes.
And I'm going to share now. I think I hope. Am I still sharing? Can
yes,
you see
you are sharing
anything?
your screen. The last page in
Right.
the presentation.
Can you see that is a big breast? Can you see this big breast?
No. اللهم علمنا بما ينفعنا. Yes, now, yes.
Okay. Now,
Yes, now.
this patient, she was 11 years old, 6 months after her puberty, and she had a breast heavier than her old body, and she's a beautiful girl. She's a Saudi, and she was sent to a pediatric surgeon who straight said bilateral mastectomy. And I said, hang on. So somebody asked me to see her. So I said, please let me have a look at this patient. I said, come on, 11 years old, bilateral mastectomy, that's mad. She couldn't stand straight because of the size of her breasts. And we got an ultrasound scan, and we got an MRI, and they have multiple, massive number, about 8 in one side and 10 on the other side. And we had a core biopsy from them, and that core biopsy came back as PASH, so the angioma stromal hyperplasia. And then we took her to theater, and what we did before we take her to theater, we just marked our mark from suprasternal notch to here, and the medial lateral, blah, 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 blah. We excised all the skin and left the nipple attached to her parenchyma to preserve her breastfeeding in the future and her vascularity. And then we excised, as you can see, a massive number of masses from each breast, about 8 from one side, and that is the smallest. I'm sorry, this is the youngest, the rarest ASH ever recorded in the world, because she was the youngest, 11 years old, the largest number, and one of them was 400 grams. We excised the excess skin, and we started radially to open the parenchyma and enucleate each one without disrupting the parenchyma as much as is possible. So we removed the skin, excess skin, we opened the parenchyma, enucleate each one at a time, and then with a purse string, deliberately we left a lot of excess skin, and there you are. And she survived. She's now 17 years old with beautiful breasts. I never needed to do any corrective surgery for her. We preserved her breast. So you can, if you have to, do these forms of surgery. But if the patient is over 30 or 35 with still fibroadenoma on one side and similar numbers on the right, it is a bilateral mastectomy with immediate reconstruction. That's what I would do. But if it is 3 or 4 here and 3 or 4 there, I only remove the biggest, the palpable one, and keep an eye on the rest. I hope that covered your question.
Yes, yes. Very good.
Yes, Dr. Ashraf. My question now is that measure you said in the myoplasty, which is 20 from the nipple to the clavicle and 11 to the sternum anterior line. This is fixed whether the woman is long or short, 11 years old, or is it fixed measures, or we can adjust?
15 to 20 is all. I hope I'm still able to do some screen share. Yeah, I will show you something, if I may. Right now, can you see me drawing now?
Yeah.
Can you see my drawing?
Yes.
No, I can't see you. You do. No, you do.
Yeah.
Yes.
I drew something.
We can see
now.
Yes.
Here is the suprasternal notch, and here is the clavicle, and here is the midline, and here is the nipple areola.
Yes.
Okay, and the distance from here. No, let me see, do it in a different way. Right. I will wipe all these. Ideal breast is like that. You see here the breast, and here the other breast, right? Can you see the meeting points of the two breasts? Ideally, the nipple areola is there. And that, if you look at the side, is where the inframammary crease is almost horizontal line with the nipple, right? And that distance usually from the suprasternal notch to there is 18 to 20, depending on the height of the patient. The patient is tall or short. But with your own eye in your clinic, when you are examining the patient, look at these meeting points between the two breasts and where the nipple is. And if you find the nipple is here, then the ptosis of this patient is that distance, right? Without you having to measure all the time. Look visually, the meeting points of these two breasts, because that corresponds to the inframammary crease, right? And measure the to where the nipple is now, and that corresponds to the ptosis. That could be 18, that could be 20, it doesn't matter. Now, if I have I will just wipe all these things from the board. Now, if I have a patient with here the meeting point, but the nipple is here, and I have a tumor, ideally the nipple, if I'm doing mastopexy or reduction mastopexy, I'm going to lift up the nipple to here, isn't it? Right. So if I have a tumor at that area, now I am an oncoplastic surgeon. I can see it. I know that I can afford to do so much excision above the nipple all the way there without compromise. Actually, I'm going to get a massive, I can do an S incision, I can do a bat wing, and I will end with a nipple there, right? So you don't have to measure all the time. You just see the meeting point of the two breasts and the position of the nipple. And if it is there, then measure that distance. That's what matters to you more than from here to there. But generally, from suprasternal to ideal nipple is 18 to 20, depends on how tall the patient is. Did I explain it reasonably well?
Yes, yes.
Yes.
Yeah. There is.
So it is observation rather than measurement.
Yeah.
Yeah. So I will remove it, and I hope that drawing just explained it to you. It is not much measurement. You can do it visually, and that's exactly the difference between who calls himself oncoplastic or a general breast. You look at the tumor, but you also observe straight away where the nipple is from that point and where the location of the tumor is. So I can use oncoplastic approach. If you ever use the S, please always remember that the distance should be the same, otherwise you twist the breast.
Yes.
So, yeah.
Dr. Nafisa is saying, please say something about neoadjuvant hormonotherapy.
Yeah, I use it a lot. I use it a lot for patients who are strongly ER/PR positive, HER2 negative. I use hormone therapy a lot with them. Of course, not many medical oncologists are keen on hormone therapy in Egypt, but one like Dr. Hebel Zawahri is very keen on it because the response to neoadjuvant chemotherapy is pathetic. So yes, I do use neoadjuvant hormone therapy. So neoadjuvant, I call it neoadjuvant therapy, not neoadjuvant chemotherapy, because it could be chemotherapy plus or minus Herceptin or just hormone therapy. Yeah. It's fantastic. I had a patient who came to me in early April. She's young, she's in her 30s, earlies, with a big left breast tumor. And she was going to a free hospital called Bahia, but they had to suspend the work for 4 months. And she came private, and she's very poor patient. And we put her on Zoladex injection monthly with tamoxifen. The hospital, her turn came, which is about 4 months later. When she went there, and the last time I examined her before she did have her operation, the tumor has reduced to less than 50% of what it was. Yeah. So yeah, I use a lot hormone therapy up front in a strongly ER/PR positive HER2 negative patients. Yes. Okay. But you cannot use it, of course, if people now start to say we use it as a primary treatment. Don't use it as a primary treatment forever if the patient is fit for surgery. But use it as a neoadjuvant, yes.
Yes.
Ashraf,
Dr.
Yeah. As we are all facing the COVID situation, we have used this quite extensively during the COVID situation when we didn't have enough capacity to operate because we are facing lots of COVID patients. And those ER positive, HER2 negative patients, we actually send them away with hormone therapy. So that could be one of the examples as well.
Nice guideline, yes. Yeah. And nowadays we say breast management before and after COVID. Yeah, it will change completely. I think not completely, but will change significantly the management this COVID-19. We used to send patients with a 1 centimeter tumor, grade 2, node negative, and ER positive, HER2 negative, and some medical oncologists say chemotherapy. But with the COVID-19, they said no, hormone is good enough. Hormone. So yeah, COVID-19 has changed a lot our practices.
Yes.
Yes.
Dr. Wael Amir saying, please specify a lecture for oncoplasty, how to plan.
Right, we're going to have a joint presentation between me and Farid. How about that, Farid?
Oh, I cannot to do that, but I can follow you. But I'll certainly, it will be my pleasure. Yes, thank you.
I will give the easy bit and then I will leave the difficult for you, inshallah, in our next meeting in 2 weeks.
Inshallah.
Inshallah.
Okay.
Inshallah.
inshallah.
Okay.
اتمنى من الله سبحانه وتعالى ان احنا قدرنا نفيد الاخوه كلهم. يا ريت اي حد، انا ليا اصدقاء من بلاد عربيه بيتصلوا بيا يسالوني في حاجات، وامانه بنديهم كل النصيحه اللي ممكنه. انا مستعد احضر مع اي حد العمليات بدون ذكر اسمي. If they want my support wherever they are in Egypt, I'm always there for them. They can all have my phone number. They can call me whenever they want. 24 ساعة في اليوم والله هرد عليهم. Thank you very much for being good listeners.
شكرا.
A good audience.
شكرا دكتور أشرف على يعني على السبورت الجامد ده، ويعني ربنا يجعله في ميزان حسناتك. والحقيقة رسائل الشكر كتيرة جدا جدا، يعني أكتر من إنها تتقري، وربنا ينفع بحضرتك يعني دايما.
اللهم امين. ربنا يكرمك وشكرا. We will meet again in 2 weeks ان شاء الله.
ان شاء الله باذن الله باذن الله.
السلام عليكم.
وعليكم السلام ورحمه الله. شكرا.
السلام عليكم.
السلام عليكم فريد.
السلام عليكم.
السلام عليكم.